Okay, I think we are now ready to start. Let me welcome you all to the webinar. My name is Edward Kataika. I am Director of Programs at the East, Central, and Southern Africa Health Community, ECSA HC for short. This is our fourth webinar in the series, organized for the ECSA Health Economics Community of Practice. The Community of Practice was established about 2.5 years ago with the support of the Translounce program. It is a platform that brings together health economists and planners, mainly from the ECSA member countries, to interact and exchange knowledge and experience on health economics related topics. These global health economics webinars are part of the knowledge exchange and continuous learning for members of the community of practice and all others interested in enhancing their understanding and capability of health economics. In the webinars, we invite experts in various health economics and related fields to share knowledge and experience in topics that are of interest to the community of practice. The topic for the webinar today is modeling to inform HIV programs in Sub-Saharan Africa. We are all aware that countries in Sub-Saharan Africa implement HIV programs among several other health programs. Most HIV programs are heavily dependent on external funding sources, and program planners do face challenges in designing programs, particularly at a time of likely funding transition towards reduced donor dependence of HIV program budgets. Decisions have to be made about the funds to be allocated to various sub-programs, often subject to budget constraints and the health system capacity to deliver those interventions. Decisions also have to be made about the allocation of resources to various geographical regions. These are some of the examples of the kind of decisions that have to be made by program planners. Models are recognized as having the potential to inform such decisions and the design of programs. There are examples of where models have been successfully used to address the challenges that program planners in the region grapple with. We will be learning from the experience of country program experts, but also experts in HIV modeling, on how modeling has informed decisions relating to HIV programming in Sub-Saharan Africa. So in the webinar today, we have 7 speakers, and I will shortly start calling upon them to share their experiences. But before I do that, just a few technical housekeeping points. First, I'd like to urge participants to use the QA box to post their questions. If you have any question, just type it in using the QA box so that during the Q&A session, the panelists can address those questions. Please do not use the chat box. Use the QA box to post the question in advance. Alternatively, we can use the raise hand feature in the participants panel during the Q&A. Just use the raise hand feature so that the moderator can recognize you and give you the floor to pose your question. And then lastly, just for our noting that the webinar is being recorded. We normally record the webinars and then we share them through various platforms so that those people who did not have the opportunity to attend the live webinar can listen in afterwards. So please take note that the webinar is being recorded. So with those few announcements, we will now go to our agenda, and I would like to invite the first speaker to share the experience on behalf of the Malawi team. And this will be presented by Ms. Rose Miranda. And Ms. Miranda is a community health and healthcare leadership specialist and has been leading the HIV program as director in the Ministry of Health in Malawi. Previously, she worked in a leadership position at a referral hospital, but also headed the ministry's community health program, a health professional training institution, and district level services. Currently, she is principal investigator of the Malawi Population HIV Impact Assessment Survey, and she is also currently a PhD candidate at the University of Malawi. So may I now invite Ms. Rose Nyirenda, who is the Director of the Department of HIV/AIDS and AIDS, Ministry of Health Malawi, to share the experience with the use of modeling to inform HIV program in Malawi. Ms. Nyirenda, you have the floor.
Thank you, Edward. Can you see my screen?
Yes, we can.
Thank you.
All right, thank you. Thank you for giving Malawi the opportunity to share our experiences. It's an honor for us. I'm not an economist, neither am I a modeler, but I'm a policymaker. So here I am having to share this forum with economists and modelers. So I may not be the best, but what I can share is how we have used modeling to influence policy, particularly in the HIV program in Malawi. Just a short background about the HIV context, which I think some of you are already familiar with. We are making a lot of progress in terms of the response, and largely we have been using spectrum model, and those are the results of our performance. And what is also striking about us is that we have got a strong HIV program data system, which uses manual but also electronic medical records in over 700 sites. And we do quarterly data validation in all facilities, and this has been there since the early 2000s. And 97% of our HIV programming is financed by donors, and of late we have been seeing a declining financial envelope. In terms of our experiences, I think I'll talk about several modeling models that we have used for our HIV programming. The famous one being the spectrum and recently Naomi estimates, which have supported our annual and subnational estimates, but also recently we've been able to disaggregate the estimates by age and gender for people living with HIV, prevalence, incidence, new infections, AIDS deaths, erratic coverage, and even the treatment cascade itself, particularly the 95 one using our recent spectrum Naomi estimates. But also we've been able to compare targets. The NSP targets we compare with PEPFAR, but also the spectrum modeling targets. So that is what we have used spectrum and Naomi estimates for. We have also used Optima model analysis. In 2017, there was an analytical support for HIV allocative efficiency improvements in Malawi. And I thought I should just summarize in terms of what it recommended. It recommended a scale-up of treatment and HIV testing for the general population, but also a district level analysis was recommended in terms of allocating of funding to hotspots to increase impact. So this was specifically about allocative efficiency. In 2020, we did the same for the purpose of informing the national strategic plan priorities, but also use the same for our global fund request. 2 years ago, 2 or 3 years ago, we also did another one. This was a calibrated transmission dynamic model and a decision analytic framework. This one was for TB preventive therapy. So we wanted to evaluate comparative health impacts and policy for TB preventive therapy. We're looking at a 6-month isoniazid preventive therapy given to people living with HIV on antiretroviral treatment across districts, or continuous IPT to the same across potentially fewer districts. So we had the results which showed us that 6-month IPT program could be implemented nationwide, and also continuous IPT alternative could be introduced in 14 of the 27 districts. But also it gave us more results. Say by the end of year 12, continuous IPT predicted to avert more TB cases than the 6-month alternative. And for both scenarios, the mean reductions in TB incidence among people living with HIV by year 12 were expected to be 10%. I thought I should share those results because there were some implications on policy, which I'm going to mention later. It also showed us that cumulative numbers of IPT-related hepatotoxicity were to exceed the number, would exceed the number of all-cause deaths averted in the first 3 years. These were very critical results because they had a lot of influence on, they were going to determine the decision that would make. Just wanted to indicate that this analysis was published in Journal of Acquired Immune Deficiency for those that want to refer to it. But recently we have also used the World Population Map and Naomi estimates for geospatial analysis. I think I have a team that is always innovative and want to try whatever in terms of using of models to guide us in certain decisions. So for this one, the goal of the analysis was to estimate the proportion of and proportional number of people living with HIV that can reach their closest relative facility on a district and traditional authority level for given times, but also geographical distances. We also wanted to produce a graded PHIV prevalence map that supports the identification of locations that may be underserved. And then we're going to incorporate the travel maps that indicate the time and distance needed to reach the closest relative facility based on a computation of elevation and land cover maps, as well as road layouts. Identify and propose new candidates, facilities for and locations for relative treatment, scaling up activities. These were the goals. And this is work in progress. We'll be finalizing soon. And we believe that this will inform our investment in the short and long-term service ART delivery models. What I've included is, this is an active map, whereby once you are moving the pointer, it will show you, it will give you all the information that has been entered into this model. And you can actually determine where you have long distances, where we need to put up facilities, or our clients are traveling long distances. Therefore, they need probably to make a decision in terms of investment. We can share the link on that. So what are the policy implications on all these models that I'm talking about? Let me mention that the first Optima analysis, which we carried out in 2017, and even the second one, it informed the policies, but also strategic guidance, as I mentioned, NSP and the Global Fund proposal. And all low-cost interventions, which were demonstrated to have impact in the models, were adopted. However, for the 2017 one, I think it was good work that was done by our consultants. But it was a challenge. We had some challenges because some costly interventions with minimal impact were prioritized by our donors and civil society because of their influence. So in terms of the allocative efficiencies, maybe the progress we've made is now with the NSP and the Global Fund, that at least all low-cost interventions were adopted to be funded. But we saw these other low impact being incorporated, I think, because of the donors, and we didn't have much say on that one. We argued, but it didn't work. TPT policy, say we had all those good results. The results were also not adopted. I think we ended up having a debate about risk versus benefits when we submitted it to government leadership. So a policy decision was not based on the results. It was based on risk and benefits. And again, the findings were not adopted as we had wanted. However, later on, we adopted one of the results, which was about implementing 6-month isoniazid, but the decision was made because of the resources that were available then, not really the science and all the other findings that were that came out of that analysis. In terms of the geospatial analysis which you have just conducted, it's something that is very exciting, and once finalized, we believe that it can easily influence policy on ministries' capital investment, on infrastructure priorities, but also even our priorities when it comes to improving access to services, either through Global Fund or even paper. But we can also use it as an advocacy tool by civil society. So all in all, I think our experiences as a department or as an HIV program have always been exciting. We have used most of the results from our modeling exercises to influence our day-to-day policies, but also even strategic direction, funding, and so on. But there are other few areas where we have not achieved much because people did not feel convinced that the model is giving us a policy direction that is favorable to everybody. So I think that is something that we have learned, but in overall, I think I would say probably 80% of the results that came from our modeling, they have been adopted as policy, or they have influenced how we allocate resources. And I think we look forward to this exercise now and again to influence our day-to-day HIV program policy, but also even beyond, just beyond HIV. And we're excited that we're working with the planning department in the ministry and even University of York and all these stakeholders. I think this is a step forward that will capacitate Malawians so that we can be able to implement modeling all the time when we are trying to make our scientific and even policy decisions. Thank you very much.
Thank you very much, Rose Miranda, for that experience from Malawi. Just to remind the participants that we can post our questions in advance using the Q&A session. You can just type in the question, which will be addressed by the panelists during the Q&A session. We will now move on to the second presentation, which will be the experience from Zimbabwe, and this will be presented by Isaac Taramusi. And Isaac is a monitoring and evaluation coordinator with the National AIDS Council under the Ministry of Health and Child Care in Zimbabwe. He coordinates monitoring and evaluation of HIV and AIDS programs and has served in this position for more than 10 years. He holds a master's in public health from the University of Zimbabwe, and he proceeded to do training in modeling of infectious diseases with the Imperial College London. So that's Isaac Taramusi. So may I invite Isaac to share their experience with the use of modeling to inform HIV program in Zimbabwe. Isaac, you have the floor.
Okay, thank you. I will present on behalf of Team Zimbabwe on our experience in the use of modeling to inform HIV programs in Zimbabwe. Can you see my screen?
Yes, we can see it.
Okay. We have an estimated population of 16 million from Inter-Census Demographic Survey report, and about these 1.3 million are living with HIV and AIDS with a prevalence of 12% and an incidence of 0.5%. And we have noted a decrease in our mortality, where we have 137 per 100,000. We have been using models, and the results of these models have been used for reporting, like for SDGs, and also monitoring our strategic plan, whether we are on track in achieving our strategic plan. We've been using also these results for resource mobilization for PEPFAR, Global Fund, and also for donor reporting. Also, these results we have been using to define our epidemic so that we'll be able to use the information on targeting and also having the picture of our epidemic patterns. And finally, the results have been used for advocacy and also for policy change. In trying to measure our epidemic, progress on our epidemic, we've been using the GOES model, where we have been also analyzing to see whether we can achieve our targets. And we had some scenarios where we could see whether if we will continue to change the epidemic curve if we implement treatment care programs and if we can scale up treatment care programs. And it helps us also to manage to measure progress, whether we are on course to achieve our NSP targets, of which we have noted that there was a decline in HIV mortality by 28% from 2015 to 2020, where there was a near miss of our target, which was 50% reduction of HIV mortality by using our modeling approach. We also used the spectrum model to be in a position to assess whether we are on course to achieve the epidemic control in Zimbabwe, where we have noted that our new infections are going down, and the trend or the graph for new infection, the trajectory for the new infection and the trajectory for our AIDS dates, they are almost closer, of which we are expecting to reach our epidemic control in the early 2020s. We have been also using these results to set targets and to explain on who is contributing what new infections. We have been using results from the incidence pattern model, where we have noted that the never married females, of which these are in the classes of adolescent male girls and young women, of which has been confirmed by the Naomi model that we've been using also. We've noted that adolescents, they are 4 times higher, their new infection, they are 4 times higher as compared to their male counterparts. And this influenced the birth of new programs like the Sister to Sister program, which is targeting the adolescent girls and young women who are in school and who are out of school as a way of trying to bridge the gap in the new infections that are occurring in the adolescents. Okay. In geo-targeting our HIV response, where we have been using Naomi and also the previous modeling that we have been using to make sure that we'll be in a position to focus our epidemic, to say maybe which areas do we need to focus, where we've noted that there are other areas where we have high rates of incidence, like the Matabeleland region, and in the northern regions where we have lower incidence of HIV. So we have been using these modeling approaches to focus our response to target to areas where we have high incidence and where we have the high burden of our HIV. We've been also using our modeling approaches to be in a position to define the programs that we can put priority, like we have been using the goals. This influenced the policy change on HIV and AIDS, where we had to make sure that the adolescent girls and young women are also screened.
Apologies to interrupt. I'm afraid we've actually lost your slides. Would you mind resharing those for us if possible?
To 18 to 12.
Thank you. Thanks so much. Thanks.
We have been also using the results to make sure that we define interventions that are cost effective by coming up with cost effectiveness plans, so that results that are high impact and which are cost savings, we scale up in Zimbabwe and make sure that we reach the maximum impact return on investment. And for example, these interventions that we had to consider were medical male circumcision, scaling up of PrEP, ART, and also HIV testing. Then there are other interventions that were cost effective, like condoms, where there are low-hanging fruits in the response, have been scaled up throughout the country to make sure that we control HIV infection. And also resource mobilization for these interventions and support from donors have been sought, informed by the cost effectiveness analysis of the interventions. Then we also used modeling to evaluate the impact of HIV prevention programs in Zimbabwe, where we've also evaluated medical male circumcision using epidemiological model, and a publication to that effect was made. And we have noted that medical male circumcision was paying off in future, where implementing or scaling up medical male circumcision was also going to reduce the treatment cost. So the recommendations are to generate more evidence using the models, that they will inform the programming, and in turn it will also inform how we allocate budgets and how we support the programs. And our support to the program should be based on high impact program, and also we need to optimize the approach in the response to our HIV and AIDS, so that our investments are supposed to be targeting on high impact programs, so that we have high return on investment. Thank you so much.
Thank you very much, Isaac Taramusi, for that experience from Zimbabwe. We had a slight technical hitch. I think we had lost your voice, but I do believe that participants have been able to follow much of your presentation. We will move on, and we will shortly hear the experience of South Africa with the use of modeling. And I will be inviting Dr. Tato Chidarikire. And Dr. Tato is the Director of HIV Prevention Programs in the National Department of Health. Her portfolio includes policy development and implementation, and management of HIV prevention programs, including HTS. She has over 20 years professional experience from academia, public health, and research, with 17 years in the HIV field. Her experience includes policy and implementation, research, and clinical trials. She has co-chaired the WHO HTS Guideline Development Group, the National PFIP Prevention Work Stream, and the National HIV Think Tank. She is a PhD graduate from Wits University with a specialty in virology. So that's Dr. Tato Chidarikire. So may I invite you, Dr. Tato, to share the experience of South Africa. You have the floor.
Thank you very much, Chair. I hope everyone can hear me and can see my slides.
Yes, we can hear and we can see the slides.
Right, I will be basically talking to how modeling is used to inform South African HIV policy, with an example of HIV testing. And this is the team that has supported us with the studies and with the results. So why do we need modeling as policymakers? As has already been mentioned by our previous colleagues, previous speaker, policy is generally informed by data and cost effectiveness, value for money. And as we actually focus on impact, we have used modeling in a very crucial way to provide guidance in terms of focusing. And as we also try to get data at a very granular level, it's very important to identify where to focus and where to mobilize our resources. So we need to identify exactly where, as I said, on a granular basis, what is it that we should scale up and to what magnitude. And again, bearing in mind that we're looking at cost effectiveness while we actually search for strategies that will actually inform us in a positive manner in terms of outcomes of the policy. So we actually need a clear evidence in terms of our interventions. And again, as I said, based on or informed by data and cost effectiveness. We look at direct comparisons in terms of different implementation models. If you keep in mind that I talked about a special focus or example of HIV testing, we are looking at different modalities or models of delivery, and looking at which one actually is more efficient as well as cost effective to direct us to the goals that we're looking at. And I also spoke about a granularized data. We need very clear targets. And again, as we focus for impact, we need to look at where there is high burden so that we can have the highest impact, also using synergies and to achieve maximum impact. So we look at geography, our impact based on geography and population, in terms of demographics. We look at age and gender disaggregation so that we're able to efficiently and effectively get to the targets that we are looking for. Again, we are targeting for impact. It is also very important to note that while we actually now expand, as testing expands and as we test more and more people, we may actually be looking at other high-hanging fruits, for lack of a better phrase, to get us to that last mile in terms of our targets. In terms of, just to make a few examples, with regards to HIV testing, we may actually need to look at strategies that actually a little bit more maybe resource intensive in terms of cost and even maybe human. Looking at modalities like index testing or partner notification, self-testing, in order for us to get high positivity and to reach those populations that are test averse and untested or under-tested. So as now that I have mentioned what actually informs policy, especially when it comes to HIV testing, let me give us a little bit of background in terms of the program in South Africa. While we know that we have made major strides in terms of moving towards the 90-90-90, with the first 90 being what we're looking for in terms of HIV testing. As South Africa, we have surpassed the first 90 in terms of the total population. We're sitting at about 93. However, when we look when you dive deeper into the data itself, we know that while we've made good progress, we have some challenges that remain, when you start to disaggregate. For example, percentage diagnosed in terms of male and females is substantially lower in males as compared to women. And when we look at the younger population, we also see some gaping gaps there among youth, which means that we are left with concerns that while testing may be able to reach other populations, it may not be as efficient, and cost effective as it could be, or we may not necessarily have to look at such as our major deciders in terms of getting to the targets. So in South Africa, really, most of the testing is run on the backbone of public health facilities, but we also have a lot of community-based testing that includes self-testing, home or house, home-based testing, as well as workplace, all the different modalities of community testing. And again, most of our response to HIV in terms of funding is domestic, even though we still have support in terms of donor funding to get us to those populations that are majorly outside of public health facilities. So we're looking at, when we look at our top right, we're looking at the total tests performed from 2002, and as we go, we see a really almost an exponential increase around 2009, 2010. And we may remember maybe that this is when we actually had that unprecedented campaign, national campaign to test, where we actually moved from around 4 million people tested per annum to just about 12 million. And from there, we've basically had a target of 12 to 14 million per annum. And in the last financial year, we tested just over 18 million. And in this financial year, that's just the recent one where we got hit by COVID. We are looking at, well, just like most countries, a little bit of a hit, but we're looking towards or working towards a target of about 14 million. So we're still going up irrespective of the challenges. And we're actually still looking at our modelers as support to see where to actually focus. And at the bottom, we are looking at the pie chart there in terms of our new diagnosis by setting. And we're looking at the line, the exponential line there in terms of positivity. So what exactly is it that we're looking for, in terms of research? I've mentioned several times, we are looking at different strategies because we're looking at efficiency as well, while we are still keeping in mind that we're looking at cost effectiveness as well as where to target in terms of, as I said, efficiency and effectiveness. We're also trying to look at our strategies that are most critical because we're looking at where to reduce the fraction, where to reduce in terms of HIV positivity, and where is it that we have populations that are undiagnosed, because we are looking at the undertested, the untested, to try and get to those that are not diagnosed and those who are HIV positive, so that we're able to stream them in terms of the management moving forward. So research as well is very important, and our modelers and our modeling has also supported us in terms of moving there. I was very much thinking about time, so I haven't really put our slide on the methodologies of the studies that have been done through our modelers. But based on the studies that we've done, and my colleague will also talk to that as well at a later stage, but we've come to conclusions that, while it's very important to use data in terms of modeling to inform policy, we also acknowledge the importance of cost effectiveness. However, we know that as we reach that last mile, as I've said before, and we're looking at the relatively higher hanging fruits and modalities such as index testing, partner notification, HIV self-screening or self-testing, we're trying to ensure that we focus on those to allow us or enable us to reach that last mile, and for us to be able to target both financially and resource-wise. We've been able to use data that we have received from modeling to ensure that we close the testing gap. And it has also supported us in reaching not just the first 90 of the 90-90-90, but we're moving towards the 95-95-95 targets too, where we'll still rely heavily on modeling in terms of where we target, how we target, what is more efficient, as well as cost effectiveness. So again, our results have actually supported us, or in a way got us to other conclusions that, again, our current testing strategies, out of all of them, testing of partners of newly diagnosed clients, OI patients, as well as female sex workers on PrEP, actually achieves the highest rates of new diagnosis. This may not necessarily be, in low cost effectiveness per se, but we're looking at now the results in terms of outcomes. Community-based testing also show that they would substantially reduce and the undiagnosed fraction, that they may not necessarily be so cost effective. In fact, they've been shown to be the least cost effective. So this brings us to my point that I've been trying to emphasize before, that while we are looking at data and we're looking at value for money, but we're also looking at results. And as we move more and more and more to expand the testing strategies, we see that we need to look at the strategies that are getting us to that last mile, getting us to identify the undiagnosed, undertested, test averse, and ensuring that we also disaggregate on that granular basis of like our adolescent girls and young women, the men, higher, a little bit of older men, and the key populations as well. And we see that assisted partner notification and HIV self-testing and target testing targeted to MSM, again, would be highly cost effective. However, we see that they would bring us the results that we may be looking at. So testing of female sex workers, again, as we've seen, as well as distribution of self-test kits to partners of pregnant women has also shown that it could be a very efficient modality to be implemented, as well as offering self-test kits as part of home-based testing. While it is less cost-effective than testing without self-testing offer, but it could, again, substantially increase the uptake. So, while we actually weigh the cost-effectiveness against the outcome, we need to actually try and use that information in terms of where we are trying to get to. And this is why we have actually been, in a way, relying quite heavily with the support that we've been getting from our modeling partners and implementers. So I think I'm going to pause it here and just acknowledge our modeling team and sponsors for their support. And I will take any questions further. Thank you.
Thank you very much, Dr. Tato Chidarikire. That was the South African experience with the use of modeling. We will move on with our presentations, and we will now listen to the experiences of the modelers. So the next presentation will be from Avenir Health. They will share their experience with the application of the Spectrum goals model in collaboration with the countries. It will be presented by John Stover. And John is Vice President and founder of Avenir Health and served as Avenir Health's first president. Previously, he was Vice President at the Futures Group in the Center for Economics and Modeling. He has over 30 years of experience in assessing population and health issues in developing countries and in providing technical assistance in policy analysis and awareness raising through computer modeling. So John will present his experience from the perspective of Avenir Health. John, may I invite you to give the presentation?
Thank you, Edward. So I'm going to be talking about applications of the goals model. And just to give you one slide to overview how the model works, this stages across this arrow here the epidemiological aspects of the model that looks at the population divided into different groups, their behaviors that put them at risk, various epidemiological factors that all lead to calculating probability of transmission and new infections. So the model uses country-specific data from surveys and surveillance and routine program data to fit the historical epidemic, and then can project forward into the future. And across the bottom, we can see here the program-related elements. So these are the behavior change interventions. These are the biomedical interventions that have a direct impact on probability of transmission. And then we can see program support functions, societal enablers, policy, funding, et cetera. So all of these elements are included in a typical application. So this model's been used for a variety of purposes, most of them already mentioned by previous presenters: strategic plans, global fund applications, investment cases, PEPFAR country operational plans, evaluations, et cetera, and has been applied in quite a few countries over the last several years. I want to focus just a few slides on what are the key questions that have been addressed with these model applications. And the first one that, and these are roughly in order as well, I would say. The first one, most important, everybody wants to know, what would be the impact of the program that we're thinking about, that we're planning? And this, of course, is an iterative process. You might have your initial strategic plan. We would run the model, see what impact that produces. If it's not enough, go back and revise some of the targets in the plan or see how it might be changed. So in these charts here, you're looking at comparison of what if we just continue our current efforts in blue versus what if we are able to achieve the new targets for our plan in orange. How can we reduce new infections and AIDS deaths? So that's really the number one question I think everybody is asking about, to use this type of analysis to help design the strategy. The second one, of course, is how much would it cost to do all that? So here we want to look at the cost by each intervention, add it all up and say, okay, what's the total cost of my program to achieve those targets? Then the obvious third one is, well, how does that fit with the resources that are likely to be available? So we need an analysis of resources that are currently available, and then some thoughts about what might happen in the future. Will the government government contribution to the AIDS program increase? And there are several mechanisms that can be looked at as to what might help increase government contributions. What's going to happen to PEPFAR contributions, Global Fund, and any other outside contributions that are expected. So we need to define the resource envelope into which we're trying to fit our strategy. The fourth one, Isaac already presented this chart, but it's just to look at which interventions are most cost effective. In this particular chart, cost per infection averted is shown on the vertical axis. So the lower you are on that axis, the better. And then the total impact in terms of number of infections averted in this case is shown on this axis. So anything in the lower right-hand corner is very impactful and is cost effective. And anything up in the upper left doesn't have a lot of impact and costs a lot. So this is a guide to start with. As was mentioned by the previous speaker, cost effectiveness is not the only criterion in which you would make a decision, but the models provide you with this information to help guide your thinking as you try to craft cost-effective and a strategy. So number 5 is then, given that information, can we find a more optimal allocation of resources? So if this SQ bar status quo shows you how resources are currently allocated, the model can tell us how an optimal allocation would look. And then we can consider, well, what does that mean in terms of increasing resources for some interventions, decreasing them for others, or making some interventions more cost effective? And that's the question number 6. How can we make programs more efficient? So here's an example of ART, where perhaps the current cost is $205 per patient, but we can conceive of various changes like switching to dolutegravir-based regimens, differentiated service delivery, using community support, that all together could reduce the cost of still providing quality services to ART patients, but at lower costs. And as we saw in the previous presentation, testing strategy is another big one. That's usually a large portion of total expenditures, but lots of different options to use different modalities, use risk screening scores to try to improve yield, address different populations. So lots of different ways in which you might make testing more efficient. Number 7, how can we allocate resources geographically? So this is an example from Tanzania, where we looked at the various regions in the country and looked at the impact and the cost from scaling up different interventions within a fixed budget. So what this chart is telling us is, where should we scale up first? So we should be scaling up VMMC in these districts, but not necessarily in these districts. We should be doing these sex worker programs everywhere, but not necessarily PrEP for young women. So you can see the results that come out here, again, are a guide, not to be followed slavishly, but a guide to optimizing your geographic allocation of resources. And then finally, another question that comes up a lot is, what is needed to achieve the global target? So we all know that UNAIDS has helped establish these global targets that include that 90, 90, 90, 95, 95, 95, big reductions in new infections or AIDS deaths. So another thing we can do is to say, how could we get there? What interventions would be required? How much would it cost? Is it feasible to mobilize this amount of resources? So my final slide is just to remind you that although we talk about the details of the model application, what's really important is the team effort to develop the strategy. So it involves not just modelers, but also experts in program data, researchers, costing experts, stakeholders, program leadership, all have to be involved in making sure that the correct data are used, the correct questions are asked, and the outputs of the model are interpreted and massaged into a cost-effective strategy. Thank you.
Thank you very much, John, for that presentation. We will move on, and next we'll listen to the Barnett Institute. They will share their experience with the application of the Optima model. And the presentation will be made by Dr. Sherry Kelly. And Dr. Kelly is a modeler specializing in global health modeling. She has led substantive allocative efficiency health modeling projects for governments of over 30 low and middle income countries across all world regions. She leads the Barnett Institute's Optima Consortium on HIV, TB, malaria, maternal child health, and COVID-19 applications and studies. She has a background in epidemiology and basic laboratory research. And prior to joining the Optima team, she worked with UNAIDS. Dr. Kelly was an invited keynote speaker at the 2019 International AIDS Society Conference, as well as a speaker at the AIDS 2020. So that's Dr. Sherry Kelly. And may I invite you, Dr. Kelly, to share your experience with the Optima.
Thanks, Edward. So I wanted to share my experiences, but luckily our colleagues from Malawi, Zimbabwe, and South Africa have paved the path beautifully. So we're just going to talk about, the side from the modelers. So in terms of providing support to help the decision makers and funders achieve the best health and budget impact and to plan for sustainability, we first have to know what are the key questions, and John laid out a lot of those questions also very clearly. But the questions that we often have as well are, if you were to cost effectively allocate your budget, then how many more infections or deaths can be prevented? Also, like John said, what are the resources needed to actually achieve the targets? If you were to scale up a certain program, what would be the impact and how much would it cost? So those are the key questions that we need to work with the country partners to see what's of the greatest interest, as well as the funders. And then we, of course, go and collect the data. That includes health data, program data, and what's the evidence on the impact. And if there are any constraints, for instance, we would never take anyone off treatment, and we have potentially some logistic constraints. If there are certain portions of the budget that are earmarked by a funder, we might not be able to move it there. Then we do our analysis, we generate results, and we go back to the actual country team and the funders and say, what do you think of these results? And then it's an iterative process so that we can come to a point where the results are the most useful and they can inform things like global fund applications, our COPs, etc. We've worked in over 60 countries for the Optima HIV application. And through this process, like I said, we want to look at what the burden of the disease is, what the response is, and then get out the actual outcomes that are the most useful. So for the 3 countries, in Malawi, for instance, Rose already let us know that there were 2 different applications. This is one of the key results from the latest application that was used to inform the 2020 Global Fund request. So the country wanted to know what was needed to inform their national strategic plan targets. And so we did optimization of their budget. So you can see in the green here, this is the treatment budget, and then there's some testing and prevention, etc., up to over $222 million in 2022. But then we, said year on year, this is what we estimate would be needed in terms of increasing the budget. So over this period, anywhere between 2 and 40 million would be needed to achieve the 2025 targets with some, spending the money in the most cost-effective way. And if this was done, we estimated that 17% more infections and 5% more deaths could be prevented over this period. We also looked at it not just at the national level, but across the 32 districts. And as you can see, some districts, of course, it's recommended to take more of the actual budget, but that's a reflection in that district of the actual burden. And you can see that the way you're actually going to spend the money between these districts is similar, but there's some variation. So we always want to dig deeper and see what is actually happening in the various regions. For Zimbabwe, we looked not just at the actual overall ART program, but we wanted to see the different modalities. And again, Isaac also went over some of these results, but we were looking at the various ART service delivery modalities, and we found that if you were to prioritize community ART refill groups over the standard individual ART refill, that you actually could get some savings, and approximately $3 million could be saved each year over this period up until 2030, while still increasing progress towards the target. So that's just one of the key examples from this study. Of course, the report, it's in 2 parts and is much more detailed. In South Africa, we did a study a little while ago that was looking just in Johannesburg. And the reason that we focused there is that it was 1 in every 5 HIV infected people living in the metropolitan area lived in Johannesburg. So the focus was there in terms of the burden. And at the time, this team wanted to see, well, what would be needed to reach the targets. So the 90-90 targets by 2020 and the 95 targets by 2030. So we looked across the different stages of the actual cascade. And in terms of actually looking to better allocate the budget, there could be savings that would be had in terms of health benefit if these targets were reached. But in order to reach those targets, usually more money is needed. And so here it was estimated that over this period, an extra $83 million would be needed. So if that could be had and the push could be made, then it was estimated that the targets could be achieved. But not just actually getting more money and actually allocating it in an effective way, but actually changing the approach. So at the time, it was looked at to apply the DREAMS approach. And if it was adopted, then more infections were projected to be averted in adolescent girls and young women. And lastly, looking over the cascade, we found that where to focus the most energy was actually to look at increasing the HIV diagnosis. And a program of testing approaches was looked at that was more innovative. An extra 100,000 to 170,000 people by 2020. So that was the big push in that period to really focus in on that one area of the cascade. And that was looked at with the team and through some of the modeling work. So the title of this talk was actually to look at some of the challenges. So there are always some challenges, but good solutions that we propose. So this is our list of general challenges and some solutions that are always examined every time there's a case study. So, as mentioned by some of the speakers already, with any study, there's missing or inconsistent data and definitions. But really the solution is to work with the stakeholders in the country team on the ground. I mean, that's the way to go, because those are the ways in having those conversations that some of these challenges can be lessened, at least. Looking at standard guidelines, for example. And when you have your data, you want to see how you can use that data to triangulate or extrapolate, so then you can fill some of those gaps. When we're looking at things like capturing indirect effects of programs for adolescent girls and young women, all those things might not be captured, so you want to at least talk about some of those extra benefits. And then when you actually get the results, what do you do with them? So, you want to make sure that those results are looked at and interpreted and make sense. And, you want to go back and forth between the stakeholders to make sure that, the results seem reasonable. And then, you don't want just that report to be published and not to be used. You want those results to go where they actually can get action. So you want to make sure they're disseminated and then action can be made. So you want to work with the development partners and, if you can at all, time the study with the planning cycles and the strategy, and to inform, for instance, a global fund application, as was done in Malawi and other instances, that could definitely have benefit. So, here I'm just highlighting the key findings from those 3 studies that I mentioned, but really in terms of solutions to challenges, it's about, careful extraction of the data and how you use it, really looking at the results, making sure they get to the right people, And in order to do that, it's really the stakeholder engagement and a long-term engagement over time that will have the best benefit. Here are some screenshots of the cover shots of these reports. They can be found at the website here. This is the Optima Consortium for Decision Science. And just want to acknowledge a great many partners in these studies and others that can be also found on our website. And with that, I'll turn it back to the chair, and thank you very much.
Thank you very much, Dr. Kelly, for that experience with the Optima model. A reminder to participants that we can pose our questions in advance by using the Q&A button. If you have a question, you can just type it in, and these will be addressed by the speakers during the Q&A session. We will move on and we'll take the last but one presentation, and this is from the University of Witwatersrand. It's experience of using modeling to inform programs in South Africa. Again, this is from the perspective of University of Wits. It will be presented by Professor Gesine Meyer-Rath, and she is a medical doctor and health economist working on the economics of infectious disease interventions in low and middle income settings. She's an associate professor at the Department of Global Health, Boston University in the United States, and lives in Georgia. She works at the Health Epidemiology Research Office, a collaboration between Boston University and the University of the Witwatersrand. Her focus lies on modeling methods for economic evaluation and translating research into recommendations for public policy. Most of our work has centered on providing recommendations and budgets based on economic analysis for the South African HIV, TB, and most recently, COVID-19 program. So, Professor Gesine, please, you have the floor. You may share your experience.
Thank you very much. Thanks a lot. I am presenting this work partially in representation of Lee Johnson, a colleague at the University of Cape Town. I know I will be repeating a whole number of points that previous speakers have made, so I'll try to be very quick. In South Africa, as has been mentioned, we have over the last decade and a half been focusing on three main models in informing HIV policy. The one is Tembisa, a South African developed model of HIV and HIV interventions developed by Lee Johnson at the University of Cape Town, which can be applied nationally as well as provincially. We've then at HERO, the organization that I work at, developed the investment case model, which adds to Tembisa the outcomes of Tembisa, aspects of cost and together cost effectiveness, to look at the allocative efficiency of different mixes of HIV interventions over the next 20 years. And then most recently, we've added the Naomi model that has been mentioned by the Malawian and Zimbabwean speakers already, a model that is used to produce HIV estimates at the district level. Just very quick example outputs from each of those three. Tembisa has most recently looked at the changing engagement in HIV care. So here you can see in blue people on ART and virally suppressed, and orange additionally people on ART but not suppressed. And you can see a nice growth in that. By the same token, the people in yellow here living with HIV whose HIV status is unknown has reduced. And for the last couple of years, we've been hitting the first 90 targets, as mentioned by Dr. Chiradi Kira. However, there is still quite a large proportion, 25% and more, of people who know their status but are not on ART. And these, of course, are not so much people who have never been on ART, but a growing proportion of people who have been on ART but have since left care for a variety of reasons. The investment case model produced these rankings of different HIV interventions at specific levels of coverage by cost effectiveness, and added to the very standard presentation of these results in a simple league table ranked by incremental cost effectiveness ratio, the notion that that we added the most cost effective intervention, increasing condom availability, to the current baseline of interventions, and reran the analysis to look at, once we had implemented that, what the next cost effective intervention would be. And we continued this until we ran out of interventions. And as a result, that league table was reorganized quite a bit, but also because we were able to take into account diminishing returns to the investment of the HIV budget, the cost for every additional life year saved increased quite a bit. And we do think that that is a more realistic representation of the cost effectiveness of interventions, of increasing intervention coverage, especially in a situation like in South Africa, where most interventions have already been implemented for a number of years at very high coverage levels. The Naomi model then produces these maps of HIV prevalence on the left and incidence on the right. There are additional analyses of service coverage, including ART, and now the most recent addition has been HIV testing, as well as male circumcision, which can then be used directly by policymakers, especially now at the district level, at the level of the 52 districts in South Africa, to set targets and identify areas to focus interventions and budgets on. So with these three models, we have over the last many years supported a number of policy and monitoring and evaluation processes. We have rerun the HIV investment case every year since 2016, which, as soon as new results are available, tends to influence policy. We've contributed to target setting for the Department of Health, that's our Ministry of Health in South Africa, as well as PEPFAR and other partners. We've contributed to monitoring progress towards the 90-90-90 and now 95-95-95 targets. We've also used the results, in particular in terms of total cost and affordability, to budget for the Department of Health, that pays for around about 85% of the total HIV program in South Africa, as well as global fund requests. And lastly, the two EPI models have been used to report to UNAIDS, both on the indicators, as well as produce annual HIV estimates. And in an optimal world, all of these things come together. I'm not the first to present that this is all working in a cyclical fashion, and a lot of that is still something we aspire to, rather than having figured it fully out. But in an optimal world, and I think in South Africa we have implemented a couple of those steps quite successfully already, we start with an EPI model that produces estimates of prevalence, incidence, but also intervention coverage, that together, and intervention impact, of course, that together with cost estimates then results in regularly updated estimates of cost effectiveness of each intervention, rather than having to do cost effectiveness analyses of one intervention at a time. Those then influence policy in that optimized intervention mixes and targets are being chosen. These then influence written policies and guidelines, which gives rise to a national level plan, for example, the National Strategic Plan. And those steps have been implemented in South Africa, at least for HIV, for a number of years now. The national plans then inform the national budgets, and that's quite important, especially for health economists, to remind everyone else that decision-making starts with a cost effectiveness analysis up here, and notions of affordability come second. And that is because, so that we don't limit our budgets to only ever finance what we can afford, but also that budgets can be expanded to fund the more cost-effective and more impactful, but perhaps more expensive interventions. After the national level budget, provincial level budgets are split out that then lead to provincial level plans that implement the NSP often, and then implementation happens. We in South Africa have a bit of a sideshow where provincial level budgets are quite closely tracked for both the execution of those budgets in the shape of expenditure, but also in terms of the performance of provinces against their targets. And that in turn then it informs implementation across the budget year, especially if budgets are overspent or performance targets are undermet. And then lastly, we have another sideshow here where implementation informs service statistics, which in turn lead to annual updates of the EPI model to be representative of the current level of implementation and impact across a number of interventions. And as you can already guess, this is all optimally happening in an iterative fashion in a cycle that churns, if not on an annual basis, so but still on a very regular basis. What we've, I think, achieved quite nicely over the last couple of years in South Africa is that a lot of these steps are in fact owned by the South African government at various levels, while we have produced tools and perhaps processes that can help with that. So that entire half of that cycle is owned by the South African government, implementation of course fully as well. So we're just adding some staff there and tools and updates of tools, but really very much at the margin. As Shelley has mentioned, there are a number of outstanding challenges and potential solutions. I'll go through them very quickly. This is the result of a recent stakeholder engagement that we had as part of a project where we interviewed government representatives as well as representatives of other funders to talk especially about the use of data from economic analyses in HIV and TB planning and program execution in South Africa. So what was identified is that, as Shelley has also mentioned, there is always, and no matter how many years we've done this and how well we think we have gotten at estimating things fairly accurately, there's still always an outstanding issue with the quality and the accessibility of both cost and program outcome data. And the solution that we suggest there is to have an in-country repository of cost data that is automatically updated whenever there's new price data or salary data available. A lot of that is already available, but the updates are currently still done manually. But to also then increase availability of program outcome data to analysts in a de-identified fashion, of course, but still to make this more regular and almost automated than it currently happens. In terms of technical capacity, what respondents identified was limited costing and economic evaluation skills within government agencies at the different levels of government, as well as an insufficient frequency of the use of this data, even where they are available. And as has been mentioned before, we are aiming at building internal research capacity in not only in South Africa, but within the South African government. And I think that is really important for across this entire spectrum of modeling and economic analysis in low and middle income countries to be more serious about the local capacity. But also to increase the frequency of mandated costing and budgeting exercises rather than perhaps academic exercises that come about whenever someone gets the funding or has the idea of looking at another economic analysis. So something that is regularly mandated by government as part of the planning cycle. And then lastly, in terms of process and governance, what we heard was suboptimal coherence and collaboration within government, both within the different spheres of government at the district, provincial, and national level, but also for, between government departments, for example, the National Department of Health and Treasury. And for that, the solution would be to establish a standing health technology assessment structure within South Africa. There are plans underfoot for that within the government, which can then mandate and review economic analyses by technical partners, rather than perhaps waiting for that skill to be fully owned within that agency, within government. And to, of course, as always, improve collaboration between government spheres and levels. That's all from me. Thank you.
Thank you very much, Professor Gesine. That was experience again from South Africa. We will now listen to the last presentation, and this is on the ECSA HIV Modeling Consortium, multi-modeling studies to inform HIV programs and the future plans for the MIPSA. It will be presented by Professor Andrew Phillips. And Professor Andrew is an epidemiologist from a mathematical background based at the University College London in the UK. He has worked extensively on HIV observational cohorts, from randomized trials, and an individual-based model of HIV transmission, progression, and the effect of antiretroviral therapy. The latter has formed the basis for cost-effectiveness analysis used to inform public health policy questions relating to HIV in both Sub-Saharan Africa and the UK. So that's Professor Andrew Phillips. And may I invite you, Andrew, to give your talk.
Hello, everyone. Thank you, Edward. So yes, I'm going to be talking about the modelling to inform HIV programs in Sub-Saharan Africa collaboration, which is pronounced as shortened to MIPSA. So as Edward said, this is convened by ECSA, the Ministries of Health and NACS in the 3 countries that we've heard from, along with the HIV Modeling Consortium. Many of you would have heard of the HIV Modeling Consortium. It's a network of epidemiologists, mathematical modelers, economists, policymakers, and other stakeholders, currently coordinated by a secretariat at UCL, where I'm based, but was originated and successfully organised for many years at Imperial College, led by Professor Tim Hallett. We support the development and implementation of mathematical modelling analyses that can inform policy decision-making for HIV programs in Sub-Saharan Africa. So the idea of the MIPSA collaboration is that it kind of builds on what you've heard so far and involves all of the speakers that you've heard so far. So the aim of it is to pull insights from multiple models with close engagement from stakeholders and under the leadership of the Ministries of Health, the NDOH and the NACS, in order to inform the design of country HIV programs in these three example HIV countries of Malawi, Zimbabwe, and South Africa. The second aim is then to enable mutual learning across models and modelers, to enable engagement on modelling between modelers and other stakeholders, and to identify critical data gaps. And we've learned a lot so far, as you would have heard from all of the speakers on these issues. I'm not going to go through this slide, but this is a list of kind of an initial list of the potential interventions that we would be considering to go in the programs. But you've heard a lot about this. I'm going to move on, and this is my final slide because I want to have time to hear your questions and to hear give our colleagues a chance to respond. So the idea of the MIPSA collaboration, the approach that we plan to take is that there will be 3 separate but linked sub-projects. So 1 project each in each of the 3 countries. The discussions led by the Ministries of Health and NACS colleagues with modelers to decide on what potential interventions should be considered. Then thirdly, the analyses conducted by the various modelling teams that wish to take part, and I'm delighted that, as I say, that the colleagues that you've heard from are going to be taking part in this along with other modelling teams. Those analyses by multiple models of the predicted health benefits and cost effectiveness of potential candidate interventions will be done, standardizing to a sort of sensible extent, but obviously allowing the fact that the models are different. Number 4, then the output from the models that will be directly compared is the list of interventions that are recommended to be implemented And if at all possible, that will be broken down by district within the country. And then we will, on the assumption that every model doesn't come up with exactly the same list in every district, we will investigate reasons for any differences, try and understand amongst ourselves reasons for differences. Some of them might lead to tweaks in some of the models, or it may just be that we understand what the differences are and we explain to our colleagues the reason for the differences, and that they can bear that in mind in their interpretation. And then finally, at the end of the process, we would hope that the modelers and the colleagues from the Ministries of Health would write a policy brief on the implications of the modelling results for policy. So that's the plan for the MIPSA collaboration. And yeah, that's all I have. Thanks for your attention. And back to you, Paul and Edward. Thank you.
Yeah, thank you very much, Andrew, for that presentation. Dear participants, there we are. We've had those 7 presentations. We have a couple of minutes before the end of the webinar, and we will now go into the Q&A session where you can ask your questions or make comments. May I now invite Paul Revo to moderate the Q&A session. Paul, please.
Thank you, Edward. Thanks to all the speakers for really very clear, really great presentations. So I think it's always remarkable to see quite the level of detail, how advanced these are, particularly undertaken in HIV. And it does seem that the HIV is really at the forefront of data analytics to inform resource allocation and guide health systems. We've had a number of common themes come through in the talks, particularly in terms of some of the challenges of undertaking analyses, ongoing data challenges, both on the epidemiology side as well as the costing side. A real emphasis on the importance of stakeholder engagement, and particularly being led by government concerns and guided by policy needs, trying to systematise the way analyses are undertaken in many ways. And it's been really clear to see that some of these challenges are really common, at least across the 3 countries of Malawi, Zimbabwe and South Africa, on which the presentation is focused, but I'm sure elsewhere as well. And we've had really good attendance on this webinar. Could I possibly ask Steph and Alex if you're able to bring the attendees into the main room, which should hopefully help discussion. But I can see we have attendees on the line from a number of countries, in addition to those where speakers are from: Malawi, Zimbabwe, Uganda, South Africa, UK, and the US. I can see also we have participants on from a diverse range of settings: Gambia, Ghana, Zambia, Uganda. So really hope now to have a fuller and discussion, also a number of attendees from international organisations. So you can ask your questions either through the raised hand feature, or if you prefer, there's the Q&A box. There's also the potential to ask questions anonymously using the Q&A box. So could I ask those of you to raise your hands or use the Q&A. I'll give you a moment to do that. So I can see one hand raised already from AJ. Could I, when you ask your questions, please could I ask you to introduce yourself and also your institution and your role. So AJ, would you like to ask your question?
Yeah, hi everyone. My name is Ajay Rangraj. I'm the lead for advanced HIV disease at WHO. So first, I just wanted to thank everyone for the really fantastic presentations. It was very, very informative and very happy to see the sort of extensive modeling exercises, you know, in the countries. And so my question really, needless to say, focuses on advanced HIV disease. And the question was really, was the advanced HIV care package, as per the current WHO recommendations, was this of consideration when sort of designing the original model? And I guess my question is directed to, you know, for the modelers who worked on the projects in Malawi and Zimbabwe. And was this a consideration when you initially developed the models? Because I did see a number of interventions considered here, considering sort of the general importance of advanced HIV disease. Over. Thanks.
Thanks. Maybe could I ask the modelers, John, would you like to begin?
Sure, although I think maybe Isaac could speak more to what was done in Zimbabwe. But yes, the full package of services provided to people living with HIV should be included in the costing, obviously. And then, you get the feedback.
Webinar. Yeah.
Sorry, are you hearing me?
Yes,
yeah.
Yes.
Yeah, we can hear you, John.
So yes, we should be including the full package of services provided to people living with HIV. And then also you get the feedbacks from getting people on treatment, which would reduce, the severity and frequency of opportunistic infections, and then preventing new infections in the first place. Thank you.
Thank you, John. Isaac or Sherry, would you have anything to add?
Yeah, thank you. We had a list of services, all the services, biomedical and also non-biomedical interventions that also may be structural interventions that will also maybe include in the models, including the coverages, their levels of coverages. And this is also done in consultation with the programmer so that you capture their interest. Then I think also maybe the other issue is on the issue that have to do with the discounting or the cost, unit cost for these models. We use the agreed national data that is from either NASA or from the surveys that would have done, like national health account surveys. Thank you.
Thank you, Isaac. Sherry, is anything to add?
Thanks. Like Isaac and John mentioned, all of these program data were captured, but with Zimbabwe, there was a special focus on the modalities, and particularly with the ART refill modalities and with the HIV testing modalities. So it was an extra sort of in-depth study, and various funders and planners were consulted across the field to try to get consensus in terms of spending values for that study, just to add that point.
Thank you, Sherry. So we have a number of participants, including Ministry of Health representatives from other countries in Africa beyond Malawi, Zimbabwe, and South Africa. So, for instance, I can see Ministry of Health representatives from the Gambia, from Zambia, and from Uganda, and maybe elsewhere too. I'd just like to invite Ministry of Health representatives in particular to come forward and ask any questions, if you're willing. Please use the raised hand feature or the Q&A box. Raised hand to indicate if you're willing to ask your questions. Could I possibly, whilst we're waiting for questions to come, could I maybe ask a question of the three speakers from the Ministries of Health and the National AIDS Commission in Zimbabwe? Could you maybe say something about the process through which you engage with other departments within Ministries of Health? So clearly there's a lot of interactions between HIV and other disease areas, but also HIV budget allocation and wider full sector budget allocation. So to what extent and how, and through what means, through what mechanisms do you engage and joint plan with Department of Planning or with other disease directorates? So I'm bringing Rose, Isaac and Tata, if you have any perspectives on that. Tato, would you like to respond?
Okay, thank you very much. In South Africa, we have several platforms, where government departments can actually communicate in terms of the response to HIV, for example, HIV, TB, and STIs. However, the coordinating structure for the HIV response is the South African National AIDS Council. But we do have, as I said, different platforms. For example, we have the National HIV Think Tank, we have the Prevention Work Stream, we have the Care and Treatment Work Streams. So while we can also kind of like on an individual basis, I can contact my counterpart, for example, in social development or in Department of Basic Education. However, if we are looking at a country response, we can then go through different platforms that we have, either through the SANAC or through our prevention task teams, the PEPFAR or the national think tanks, depending on which stream we are looking at, whether it's prevention or care and treatment. We also have the TB think tank and the work streams under that. So there are quite channeled streams where we are able to communicate, including the fact that we can actually just reach out to our counterparts as per need. Thank you.
Thanks, that's very clear and helpful. Isaac.
Okay, thank you, Paul. In Zimbabwe, the National AIDS Council is the one that coordinates the HIV activities under Ministry of Health as the parent ministry. And our platform, we have a National Partnership Forum, which encompasses almost all of the response under all of the response groups in HIV that will help us also to communicate the findings and also of the HIV response, the coverages that also gives in the gaps that we are in HIV response. We have also several technical working groups and also working committees that are aligned, like prevention, treatment, care, and that focus on other enabling structural interventions that we also use to communicate the findings, and also for advocacy in special groups in policy and also intervention, change, and focus. Then
sorry, we seem to have lost you, Isaac. The line has gone quiet, but thank you. That was clear. We can maybe come back to in a moment. I wonder, Rose, if you have reflections on this. Or if not, we can move on to other questions. We are behind time. We were due to finish at past. We understand if anyone needs to drop off the concluding, including panelists. But we will try to, let's see if we can continue for another 5 or 10 minutes or so, just to ensure there's opportunity for everyone to ask questions and continue the discussions. So looking, thanks, you can see that a number of questions have been answered, but I may still come back to these. And good colleague who worked with me for years, Mead Over, is on the line. And Mead, I think you're dying to ask questions about economies of scope and scale. Could I maybe invite you to a question?
Hi, Paul. Thanks very much. Well, actually, I've very much appreciated the responses I've received in the Q&A from both Gesina and John, and also just now from Sherry. So thank you for those responses. I know that 10 years ago when I was beginning to work on this, and all of us were, unit costs were the only type of cost that anyone wanted to talk about. So I'm actually quite pleased to see that that's no longer the case, and that economies of scale are being recognized fairly generally. Sherry did not mention the possibility of incorporating economies of scope in the Optima model, whereas I would have thought Optima would be the would have the modeling structure that would most enable an analysis of economies of scope, or as others call it, economies of integration. So I'm wondering if we could hear more from Sherry about that.
Thank you, Mead. Sherry, hear more about how you model economies of scope or integration in Optima.
Thanks, Mead. So yes, the structure is there, and of course, I'm not an economist, but looking at the economies of scope, can you give me an example for what you haven't seen sort of shown in terms of economy of scope, Mead, so I can customize my answer to better address exactly the need? Because it could be interpreted many ways. We've discussed it internally.
It certainly can. And economies of scope can be narrowly defined as the economies of integrating, say, STI treatment and care with HIV treatment and care, or with antenatal clinic operations, or they could be more generally described as the economies that might be achieved by integrating HIV services generally, sort of streaming them into the operation, the routine operation of public health and public hospital systems.
Right, thanks. So for that example, I mean, we of course integrate the impact, the costing for the STI programs within the Optima HIV model. So that's incorporated. But I guess maybe taking it back a step, what we're looking at, for instance, in the Optima TB model is a component of Optima HIV response. So if someone presents with TB, but they get an HIV test and they test positive, they first need to be treated for HIV. So we incorporate what the added costs and also benefits of treating the two different infections within that model. What we're actually working on is, because the Optima platform is the same across Optima TB, Optima HIV, and Optima Malaria, as well as other models like Optima Maternal Newborn Child Health, is actually to look across that entire economy of scope and to see where the sharing of resources and the benefits between sharing those resources can actually add extra benefit into the public health response. Is that what you're getting at, Mead?
I have to unmute. Yes, that's very much what I'm getting at. And I think part of the difficulty is, of course, there doesn't exist much empirical data on the economies one achieves when integrating resources. So how do you actually proceed when you try to do that?
Right. So I think the best example that we have so far is when we looked at maternal health and family planning interventions. And of course, they have different co-benefits in terms of looking at increasing the education level, and then having women stay in the workforce, so workforce participation, and also decreasing mortality and increasing life expectancy. And so we have a component there where if you treat someone who is HIV positive and is a mother, then you have those kind of knock-on effects or downstream effects, and we captured it in the very long term as well. And we showed, return on investment and, different discounting, and we have to look at it in a bigger picture. And I thought that was a really good and maybe the best example that we did in a study with the UNFPA. And we did it in small islands in developing states, but we're also doing it in other countries. And so I thought that was a really good example. But we, like you said, with the evidence, we consulted experts in the field that have looked at this for a long time to see, well, okay, if you treat a mother with HIV, then how much education could you then receive in addition? And how long could you stay, how much longer could you stay in the workforce? And what's the actual boost to the economy, and how much, the sort of the health benefits. So just looking at all the aspects of responding to an HIV.
Thanks, Jerry. That's
just a follow-up question. I'm curious, what small islands did you model?
Right. So there were 9 in total. There were 5 from the Pacific, and there were 4 from the Caribbean. I can get you the full list, but now we're focusing even more in Laos and in Papua New Guinea and in Timor-Leste. But there's a list of 9 countries. I mean, it's a long list, but I can maybe just post the link to them in the channel.
Thanks, Sherry. That's fascinating to hear, and it really seems a good demonstration of how modelling in HIV can lead to benefit in terms of both other areas of health, but more widely as well. And that clearly raises lots of questions about how that can be modelled and how those benefits, which go well beyond HIV and well beyond health, can be captured as well. I think it's another example of how HIV is leading the field of resource allocation, and research questions arise from that. I'm just wondering, again, just encourage you to raise your hands if there are any remaining questions. I think we've got time for one or two more before we need to close. No, if not, I know it's a number of people on the call. It can be daunting sometimes to raise questions, but please do. I'd really be keen to hear again from people from working in countries beyond Malawi, South Africa, in Zimbabwe, reflections on how modelling is used within your settings. So colleagues in Uganda, Gambia, and elsewhere, please do let us know, raise your hands and inform us of your experiences. Just give a few more minutes for that. Just checking the, I wonder if there's a number of questions which were in the Q&A, but I think the response has been comprehensive to these, but if anyone would like to, if you've typed your question and you would like to provide this verbally, please feel free to do so. Okay, I think we're over time. I'll give just last chance for any final questions before we head over to. I can see one hand here as Director Jibril from the Gambia. So Director.
Thank you very much, Prof. And thanks, colleagues, and other professors around the world for the fantastic presentation. I've followed through the presentation very keenly, and it's actually very interesting. And I was wondering whether we can also be, have the same opportunity to, to do some of this modeling, in country to inform our HIV response, and also TB and malaria. Although we are, we are not a high prevalence country in terms of HIV. And for malaria, we are almost at the pre-elimination stage. But it will be actually be very interesting to have some of these capacities to be able to actually do this type of modeling to inform, decision making, so that we can actually, fast track our malaria elimination, and also, sustain the gains on TB and also HIV, and also, and this covered, response. So, my mind is not actually a question, but it's a general comment, and probably to see how, we can have some of these experiences to also, use our country's data to be able to actually inform, decision-making process in HIV and TB interventions. Thank you, Paul.
Thank you, Jibril. Jibril is the Director of Planning from the Ministry of Health in the Gambia. I wonder, John, Sherry, or other modelers, if you are working at all in the Gambia or in West Africa, if you'd like to mention that, or if not, it sounds like there's an invitation for work to be undertaken there. I think once you've given your responses, I'll hand over to Edward.
Yeah, Paul, one thing, sorry, it's the Global Fund, they are this current cycle. In fact, our initial proposal has been, we were asked to go into, iteration, meaning, it has not passed the TRP, and then some of these issues that have been mentioned here are some of the, actual TRP comments, So I was actually thinking that if you have had this, actual opportunity earlier, would have not actually, I hope the TIP comments will not be relevant, because we will actually address, most of the issues, that they have actually raised, So basically, we want to see how we can capacitize our people, in country to be able to do some of this modeling to inform, to inform intervention. Yeah, over basically.
Thanks so much. Clearly, the role of modelling in informing the Global Fund applications and also through other funders is key. Could I ask John, Sherry, or any of the other panellists to provide any final comments, reflections? If there's any work you'd like to highlight in West Africa, now is a good opportunity to do so. John or Sherry?
So this is John. Just to say that we have worked with a number of countries in West Africa on their Global Fund applications at the express invitation of the Global Fund. So, and then of course, that UNAIDS also supports a lot of modeling around investment cases that are used as the basis for Global Fund applications. So there's definitely, I think, capability and interest to do that. I would suggest you, let us know more formally about your needs, or contact your Global Fund or UNAIDS representatives and request this additional help. And I'm sure that we could organize both to provide you assistance to apply the models, but also to get some training for your staff so they could do it themselves. Thank you.
Thank you, John. It's really helpful. Sherry, any comments?
Thanks. Like John, we've supported several countries in Western Africa, including Cote d'Ivoire, Nigeria, Senegal, and Togo. We haven't had the opportunity to support the Gambia, but again, like John suggested, several funders like the Global Fund and the World Bank as well do support these countries. So you're welcome to engage them and see what's possible, or you're welcome, to contact our team, and I put my email in the chat, or you can contact our sort of general email as well, and that will get sent to a lot of people. Thanks.
Thank you, Sherry. I could maybe just finally ask Andrew Phillips if he has any final comments or reflections before we move to close the webinar. Andrew?
Thanks, Paul. No, I don't have anything other than I'd just like to thank everyone, all of the speakers. This has been a really, really interesting and helpful webinar, and thank you all for hanging on over time with your attendance. So yeah, thanks to everyone. That's all. Back to you, Paul and Edward.
Thank you, Andrew, and thanks to all the panelists and to all of the attending. It's been a really fascinating webinar and discussion. So I'd like to hand to Edward for the close. Thank you.
Yeah, thank you very much, Paul. Yeah, this brings us to the end of the webinar. And what remains for me is also to just thank all the participants for joining and for the active participation. And yes, this was a very well attended webinar, looking at the numbers that joined today. Of course, some had to drop off along the way, but it shows that this is a topic that has attracted a lot of interest from the community of practice and the beyond. Let me also thank all the 7 presenters for your good presentations and sharing your experiences. And I think this was very good for the community of practice, because it gives another perspective to the very issues that the economists and the planners deal with every day. It does enrich our experience and understanding of the tools that are available and may be used to inform our decisions relating to programming and resource allocation. So I believe that this has been very good. I see that maybe going forward, there will be more interaction between the modelers and the program people and the health economists. So thank you very much once again for attending, and we look forward to interacting with you again in our upcoming webinars, and we will be communicating in the usual way, announcing the dates and topics for future webinars. So thank you very much. The webinar is now closed. Thank you.